All right, I'm too excited, guys. So I think I'm going to start now for my grand rounds. Good morning, everybody. My name is Tritia. I am a renal fellow here at the University of Colorado. And today I will be discussing AKI and liver disease for my grand rounds. Thank you for joining me today. So the objectives of today's talk will include defining AKI and cirrhosis, summarizing the pathogenesis of HRS, understanding the workup of AKI and liver disease, demonstrating the management and treatment of HRS, and discussing novel biomarkers and imaging studies that may improve diagnosis of AKI and cirrhosis. Next, we'll be going through the outline, which essentially echoes what I just went over, as well as going further in depth into the prevention of HRS, workup and management of AKI as a general review, and then further discussing, as I mentioned, the biomarkers and imaging studies involved. So introduction, advanced cirrhosis is characterized by this impaired liver function, portal hypertension, increased splanchnic blood volume, the hyperdynamic state with increased cardiac output, systemic vasodilatation, a state of decreased central blood volume, and systemic inflammatory response. AKI occurs in up to 50% of hospitalized patients and has been associated with higher mortality. HRS is a phenotype of AKI characterized by decreased kidney blood flow that is unresponsive to volume expansion. The term hepatorenal syndrome was first introduced in 1939 to describe acute kidney injury after biliary surgery or hepatic trauma. Traditionally, HRS has been classified into two types, type 1 and type 2. Type 1 is characterized by this abrupt decline in renal function, abrupt referring less than 2 weeks, and defined as a doubling of baseline creatinine level to greater than 2.5, or a 50% reduction in creatinine clearance to less than 20. Type 2 is slowly progressing kidney dysfunction, clinically translating into diuretic refractory ascites. So AKI diagnosis is controversial due to a lack of unified diagnostic criteria. Just to kind of go over the overview of this, the Acute Dialysis Quality Initiative, or ADQI group, first proposed the RIFLE diagnostic criteria in 2004. On the basis of the RIFLE criteria, the AKIN, or Acute Kidney Injury Network criteria, was later established in 2007. Partly based on the AKIN and RIFLE criteria, KDIGO, or Kidney Disease Improving Global Outcomes, published their standard for the evaluation and management of AKI in 2012. The use of RIFLE or AKIN criteria for renal insufficiency in cirrhosis, though, has several limitations. Traditionally, the diagnostic criteria for cirrhosis-related AKI are an increase in serum creatinine greater than or equal to 50% of baseline and greater than 1.5. This threshold of serum creatinine may represent a degree of renal dysfunction that's too advanced for treatments to be effective. Since 2015, the International Club of Ascites, or ICA, classifies HRS1 as HRS-AKI. The new definition is based on the diagnosis of AKI in accordance with their criteria as a rise in creatinine greater than or equal to 0.3 milligrams per deciliter within 48 hours, or an increase greater than or equal to 50% from baseline. No response after 2 days of diuretic withdrawal and plasma expansion with albumin, absence of shock and no current nephrotoxin exposure, and no signs of functional structural kidney injury, which is the absence of proteinuria greater than 500 milligrams per day, presence of hematuria greater than 50 red blood cells per high power field, and normal kidneys on ultrasound. Urine output has been found to be a sensitive and early marker for AKI in critically ill patients with cirrhosis, and is associated with adverse outcomes. Therefore, regardless of any rise in serum creatinine, decrease in urine output, or development of anuria should be considered as AKI in patients with cirrhosis until proven otherwise. Changes in the definition of AKI and cirrhosis has led to changes in definition of HRS, allowing for earlier diagnosis and treatment. A major limitation of the HRS criteria is that it does not allow for coexistence of other forms of acute renal. Someone has the mic on. ADQI has proposed the term hepatorenal disorders to describe all patients with advanced cirrhosis and concurrent kidney dysfunction. So moving on to the pathogenesis of HRS. Cirrhosis is characterized by this reduced systemic vascular resistance due to splanchnic arterial vasodilation. In the early stages of disease, there's moderate splanchnic vasodilation and reduced systemic vascular resistance, which is balanced by increased cardiac output. But in the later or advanced stages of disease, increased synthesis of the vasodilator factors results in more pronounced vasodilation that can't be balanced by this increase in cardiac output. This results in effective arterial hypovolemia as a consequence of this disparity between the intravascular blood volume and the markedly dilated arterial circulation. Cirrhotic cardiomyopathy is a condition combining diastolic dysfunction, blunted increase in cardiac output after stimulations, and electromechanical abnormalities. Inflammatory response during cirrhosis with increased circulating levels of TNF alpha may contribute to blunted cardiac response. Advanced stages of cirrhosis with ascites, decreased cardiac output seems to precede the occurrence of HRS. Decreased cardiac output may precipitate the decline in kidney blood flow. Eventually, changes in hemodynamics in the kidney and the altered autoregulation of kidney blood flow contribute to the decreased GFR. So in order to maintain the arterial pressure, systemic vasoconstrictor systems, of course, referring to the RAS system, sympathetic nervous system, and arginine vasopressin presence, are activated along with increased cardiac output to help preserve that kidney blood flow. This ultimately leads, though, to the kidney vasoconstriction, sodium retention, which results in edema and ascites, solute-free water excretion resulting in hyponatremia, and decreased GFR. HRS develops when kidney vasoconstriction occurs in advanced stages of cirrhosis and kidney perfusion is no longer compensated by that increase in cardiac output. This next slide will cover the mechanisms of AKI and HRS in cartoon form. So if you're more of a visual person, panel A goes over the cirrhosis and portal hypertension, usually in earlier stages, as opposed to panel B, which is the advanced cirrhosis and portal hypertension. I went in depth in those slides before about the vasodilation theory, and I'll go into further about the inflammatory theory, but just to cover it. As we said in vasodilation theory, splanchnic vasodilation occurs, this effective hypovolemia, which activates vasoconstriction systems that I had mentioned. And then there's a compensatory increase in that cardiac output, as well as this arterial vasoconstriction, inflammation, microvascular changes in the kidney, ultimately resulting, as I said, the high cardiac output, this ascites, as well as increased kidney susceptibility to ischemia, but there's still normal GFR here. And then in the inflammatory theory, which we'll go over for more in depth in just a moment, there's this presence or the bacterial translocation. There's pro-inflammatory cytokines that also results in inflammation for vascular. In the advanced cirrhosis and portal hypertension stage, here, as you can see, evidenced by the multiple plus signs next to that splanchnic vasodilation, they're also more susceptible to bleeding or that reduces effective volemia, such as the use of lactulose-induced diarrhea. Infection can also affect this, as well as causing pro-inflammatory cytokines. And then I mentioned that presence of cirrhotic cardiomyopathy. Here, though, ultimately, there's normal to low cardiac output, ascites, but then you'll see a decreased GFR in the presence of AKI. So moving on to go into further about the systemic inflammation. Translocation of bacteria and or pathogen-associated molecular patterns from the gut due to altered intestinal permeability occurs. There's this overexpression of tubular TLR4 in the subset of patients with HRS that shows that overexpression in their tubular cells. It shows evidence of tubular cell damage as well. Inflammation may contribute to the systemic circulatory changes and compromise perfusion, as shown in that last slide. And patients with bacterial translocation have increased levels of TNF alpha, IL-6, and nitric oxide. About 30% of patients with HRS have SIRS without any documented bacterial infection. So in prevention of hepatorenal syndrome, this includes preventing progression of liver disease in the well-compensated patients, reversing decompensation in patients who have advanced cirrhosis, and avoiding agents known to exacerbate AKI, and preventing factors that impair circulatory status and reduce kidney perfusion. I think someone still has their mic on. There's just a lot of background noise. If we could just make sure everyone's on silent. And then going further into prevention of HRS, Prophylactic antibiotics to prevent SBP and after variceal bleed have been shown to be effective, as well as the use of IV albumin in patients with SBP and large volume paracentesis. So we typically, again, it's standard of care to give 1.5 grams per kg on day 1, followed by 1 gram per kg on day 3 for SBP treatment with IV albumin, as well as administration following a large volume paracentesis, usually more than 5 liters. Going a bit more in depth into the primary characteristics of SBP. Advanced liver disease and low acidic fluid protein concentration have been identified as risk factors for SBP and cirrhosis. Moreover, renal impairment and hyponatremia increase mortality rate of this infection. So there was this study that was published in 2007 that was a prospective, multi-center, randomized, double-blind placebo-controlled trial that compared oral norfloxacin with placebo. The norfloxacin administration reduced the 1-year probability of developing SBP with a p-value less than 0.001. It also reduced the incidence or presence of hepatorenal syndrome with a p-value equal to 0.02, and improved the 3-month as well as the 1-year probability of survival compared with placebo. I included that figure 2 there because I just thought it really highlighted the differences in placebo again compared to the administration of norfloxacin with the probability of HRS, as I pointed out with the p-value of 0.02. Besides the use of antibiotics for SBP, preclinical studies have also shown an anti-inflammatory effect of albumin in patients with cirrhosis. And we know that systemic inflammation in patients with cirrhosis contributes to the kidney failure and death, as I showed on the prior slides. So clinical trials of albumin, though, have shown conflicting results. So for instance, we know that IV albumin has benefit, as I said, in treatment for spontaneous bacterial peritonitis, but there is no evidence that albumin, in addition to antibiotics, reduces the incidence of AKI in patients with bacterial infection other than SBP. In one randomized trial published in the Journal of Hepatology in 2015, it was shown that albumin infusion delayed onset of renal failure, but it did not improve renal function or survival at 3 months. Which leads me to the ANSWER study, or the human albumin for the treatment of ascites in patients with hepatic cirrhosis. This study was published in The Lancet in 2018, and they randomly assigned patients with cirrhosis and uncomplicated ascites who were treated with anti-aldosteronic drugs greater than or equal to 200 milligrams per day, as well as who were already on Lasix for greater than or equal to 25 milligrams per day to receive either the standard medical therapy treatment or standard medical therapy treatment plus human albumin. And that was referring to administration of 40 grams of IV albumin twice weekly for 2 weeks, and then 40 grams weekly for up to 18 months in outpatient setting. In this controlled trial, long-term administration of albumin in patients with decompensated cirrhosis was associated with reduced rates of SBP, HRS, as well as improved survival. So I would be remiss if I was talking about the use of IV albumin in cirrhotic patients without talking about the ATTIRE trial. So the ATTIRE trial, it was a randomized trial of albumin infusions in hospitalized patients with cirrhosis that was published in the New England Journal of Medicine in March 2021. It was a prospective, interventional, multi-center, randomized, open-label trial involving hospitalized patients with decompensated cirrhosis, acute complications, and an albumin level less than 30 grams per liter, or if you are not across the pond, then it's 3.0 grams per deciliter, which is what we're used to. Patients were randomly assigned to receive either the targeted therapy, which involved 20% of IV human albumin solution for up to 14 days, or until discharge, whichever came first, or they received standard care. So going into the study, their composite primary endpoints was new infection, which they defined at the discretion essentially of the attending clinician, kidney dysfunction, which was defined as a serum creatinine level at least 50% higher than level at randomization, or increase in serum creatinine of 0.3 or more within 48 hours, or initiation of renal replacement therapy, as well as looking at the death between 3 and 15 days. So as I mentioned, intervention essentially was standard medical therapy versus standard medical therapy and IV albumin, but with a targeted serum albumin, again, of 3.0 grams per deciliter, in which they were going to receive the 20% human albumin. And again, the infusions continued for a maximum of 14 days or until they were discharged. The results showed that a median total infusion of albumin of 200 grams with an interquartile range of 140 to 280 per patient was administered to the targeted albumin group, compared to a median of 20 grams with an interquartile range of 0 to 120 in the standard care group. So this is represented by this figure here. I think it shows it really well from this paper. In panel A here, you'll see, so on the x-axis, it shows the days of trial treatment. Remember, again, on day 1, they were already receiving targeted therapy with the administration of the 20% human albumin to a goal of 3.0 of serum albumin. And you'll see that the daily, on the y-axis, the daily mean amount, it's anywhere between 50 to 60 on that first day alone, grams per patient, as opposed to this darker standard care group that's represented here, which was, just about 10 grams. And then if you look at panel B, this is actually showing, again, days of trial treatment on the x-axis, and the y-axis is looking at the daily mean serum albumin. So everyone started around the same, anywhere from 2.0 to 2.5 grams per deciliter. And they were really, really trying to get them up to that target of 3, as you can see already by day 2 in the intervention albumin group or targeted therapy group. And they were able to maintain them between 3.0 and 3.5, as you can see here. Whereas in the standard care group, their serum albumin didn't really budge too much, and he stayed closer in between 2.0, but closer to 2.5 as shown here. So the percentage, though, of patients with a primary endpoint event did not differ significantly between the two groups. There are more severe or life-threatening serious adverse events, especially pulmonary edema or fluid overload, in the albumin group than in the standard care group. So in conclusion, there was a near triple difference, 200 grams per 20 gram versus 20 grams, and the amount of albumin infused between the groups, in an absence of benefit across all subgroups and endpoints. These data support the need for a reevaluation of the use of albumin in patients with cirrhosis. Besides talking about the prophylactic antibiotics in SBP patients and the use of IV albumin, we would also have to mention the use of beta blockers, specifically, again, prevention of HRS. So beta blockers are very effective at preventing variceal bleeding and are widely used in patients with cirrhosis with significant portal hypertension. A recent meta-analysis suggests that the use of beta blockers is not associated with a significant increase in mortality in patients with ascites or refractory ascites. However, there was some series in which increased mortality was observed in patients with refractory ascites that were receiving beta blockers compared to those patients who were not on it. It's also been suggested that beta blockers could precipitate AKI due to the decrease in cardiac output. Risks and benefits, of course, should be evaluated on an individual basis in patients with refractory ascites. Now, since we finished talking about the prevention of HRS, let's move on to the management and treatment of HRS. It's important to investigate the etiology of the AKI, as advanced stage AKI has been associated with higher mortality. Resolution of HRS possibly improves short-term survival. It's also important to exercise caution when administering fluids in patients with AKI, so as to avoid development of significant fluid retention and pulmonary edema, given the presence of the reduced kidney sodium and water excretion in patients with cirrhosis. Next, we'll be moving on to the workup and management of AKI, in which I use this algorithm that was available from the hepatorenal syndrome review that was published in CJSON. So just very much a review, as I said, of categorizing AKI into, as we usually say, our buckets: pre-renal, renal, and post-renal. Pre-renal, of course, referring to pre-renal azotemia, as well as HRS. Renal, we can't forget about this in working up any AKI and liver cirrhosis involving any sort of GN, ATN, or AIN. And then post-renal, which could be BPH or ACS, like abdominal compartment syndrome. So intrinsic, I'm just going to start there in the middle. Of course, discontinuing nephrotoxins, working up for sepsis. Usually in this indication, though, there's no real role for volume expansion for the risks I just mentioned of fluid overload and pulmonary edema. You would do further confirmatory testing as well as specific therapy. In the event if this is more likely of a post-renal AKI, of course, we check for post-void residual. We're all fans of that Foley placement, as well as kidney ultrasound, as well as monitoring bladder pressure and paracentesis for tense ascites, again, especially for concern for abdominal compartment syndrome. But now moving back to pre-renal here. So pre-renal, discontinue diuretics, work up for sepsis as usual. But then it further categorizes, breaks it down into those patient population who appear clinically volume depleted versus not obviously volume depleted. So if there was concern for volume depletion based on the history of this overdiuresis picture, if there was diarrhea, as I said, lactulose-induced diarrhea, and worried about their volume status, then it's recommended to give crystalloid and or 5% albumin, then assess AKI evolution at 48 hours. If there's resolution, then continue with surveillance. On the other arm here, if they're not obviously volume depleted, you would give 25% albumin and 1 gram per kg in the first 24 hours with a maximum of equal to or less than 100 grams. Assess AKI evolution at 48 hours. And there, again, if there's resolution, you continue surveillance. But if there's persistence or progression, you have to question if this is HRS versus ATN. So HRS, the first line standard of therapy is to give vasoconstrictor and albumin. Terlipressin is first choice, and norepinephrine where terlipressin is unavailable. You adjust the dose according to a response to therapy, referring to the decrease in serum creatinine greater than or equal to 25%. If there's no improvement in kidney function, you would consider kidney replacement therapy. But if there was improvement, you could continue the vasoconstrictor and discontinue therapy if their creatinine is at or near baseline. Or if there was any sort of ischemic complication or volume overload, then go down and consider again the kidney replacement therapy route. If there was following discontinuation of treatment, any sort of recurrence concern for HRS, then you're just pretty much in this whole cycle all over again. So in looking up and going over the management and treatment of HRS, this is kind of not necessarily entirely related, but I went down this rabbit hole of Dr. Schreier's work in AKI and cirrhosis, and I came across this case study that was published in 1984 regarding HRS and effective central blood volume. So it was a case study of this 47-year-old female who had this severe decompensated alcoholic liver disease with progression and deterioration of her renal function with a creatinine of 4.0 that was noted. They were attributing this, of course, to HRS. And so for those like myself who was not familiar that head out of water immersion therapy was something that was used for patients specifically more like in nephrotic syndrome in children, I had to look that up just to be sure I understood what it was. And it's just what it sounds like. Patient is seated in this upright position with water up to their sternal notch. And the water immersion produces this potent natriuretic and diuretic response, which was known to increase effective central blood volume because it led to the significant shift of blood from the periphery to the intrathoracic circulation, followed by an increase in central venous pressure and heart volume. So they treated this patient with 5 hours of head out of water immersion therapy as an attempt to reverse the HRS. They monitored with a Swan-Ganz catheter and were able to show that her cardiac index, stroke volume, and systemic vascular resistance increased. She did have a modest improvement in her creatinine, urea, inulin, and PAH clearances, but their results indicated that a considerable increase in effective blood volume did not restore the renal function in HRS. Granted, this was an N01 case study, so I just thought that was kind of interesting to see our progression. In 1984, this is something that was considered and where we're going to today, which leads me to pharmacologic therapy. So as I mentioned, the first line treatment option for HRS includes vasoconstrictors and albumin. This is a summary table I put on the slide here of randomized controlled studies of vasoconstrictor therapy in type 1 HRS. As you can see, there are 8 studies listed here with comparisons between various combinations of terlipressin versus norepi, terlipressin versus placebo, terlipressin versus albumin, and terlipressin versus midodrine with varying results. Leading me to talk more about terlipressin, which is a V1-mediated vasoconstrictor. It's most commonly used vasopressin analog, a prohormone of lysine vasopressin. It has vasoconstrictor activity in the splanchnic and systemic vasculature. Within 30 minutes of administration, it can decrease hepatic and renal arterial resistive index, increases systemic vascular resistance and mean arterial pressure as well. A large advantage, of course, of terlipressin over noradrenaline or norepi is that those require a central line and ICU admission for administration, whereas terlipressin does not. Terlipressin instead is administered by IV boluses at starting doses of 0.5 to 1 milligrams every 4 to 6 hours, with a progressive increase to a maximum dose of 2 every 4 hours, resulting in 12 milligrams per day in cases of non-response, which are considered those patients who have creatinine less than 25% reduction of baseline. Treatment is recommended to be maintained until complete response or for a maximum of 14 days in case of partial response or non-response. And continuous infusion of terlipressin at doses of 2 to 12 milligrams per day has been shown in a single study to be as efficacious as bolus administration, but with lower rates of adverse events. So the most serious side effects of terlipressin are related to vasoconstriction, which is not surprising, a risk of myocardial infarction, as well as intestinal ischemia. The most consistent predictor of response to terlipressin and of survival is the baseline serum creatinine. Studies in the use of vasoconstrictors with lower serum creatinine and in early stages of HRS are lacking. Now, the efficacy of terlipressin plus albumin in the treatment of HRS has been proven in a large number of studies, with a response rate ranging from 25 to 75%, which leads me, of course, to talk about the CONFIRM trial. So terlipressin plus albumin for the treatment of type 1 HRS or CONFIRM trial was a randomized, double-blind, placebo-controlled, and developed under a special protocol assessment agreement with the FDA as a phase 3 registration trial. The main objective, just like its name, was to confirm the efficacy and safety of terlipressin plus albumin as compared with placebo plus albumin in adults with cirrhosis and HRS1. Patients were randomly assigned at a 2-to-1 ratio to receive either the terlipressin plus albumin or placebo plus albumin. Eligible patients had HRS1, cirrhosis, ascites, and rapidly progressive kidney failure, with a doubling of serum creatinine to at least 2.25 within 14 days of randomization. A total of 199 patients were randomized to receive terlipressin and 101 to placebo. The intervention. So 1 milligram of terlipressin or placebo was administered IV over 2 minutes every 5.5 to 6.5 hours, together with albumin, which was strongly recommended to be 1 gram per kg of body weight to a max dose of 100 grams on day 1 and 20 to 40 grams per day thereafter. Treatment was continued until 24 hours after a serum creatinine value of less than or equal to 1.5 was obtained, or to a maximum of 14 days. If serum creatinine decreased by less than 30% from baseline on day 4, the dose of the study drug was increased to 8 milligrams per day. So a primary efficacy endpoint that they looked at was this verified reversal of HRS. What does that mean? It was referring to as, or defined as 2 consecutive serum creatinine measurements less than or equal to 1.5 at least 2 hours apart up to day 14, and survival without renal replacement therapy for an additional 10 days. Secondary efficacy endpoints include the incidence of subjects with HRS reversal, durability of HRS reversal, which was referring to HRS reversal without any sort of need or without renal replacement therapy to day 30, incidence of HRS reversal in the SIRS subgroup, and reversal of HRS without recurrence by day 30. The results. In the terlipressin group, 32% of patients achieved the primary endpoint of verified reversal of HRS1 versus 17% of the placebo group with a p-value equal to 0.006. So if you look, the incidence of subjects with a secondary efficacy point, they actually were able to complete 3 of the 4 with significant results. And those 3 were the HRS reversal, durability of HRS reversal with no renal replacement therapy through 30 days, and HRS reversal in patients with SIRS in that subgroup. The reversal of HRS with terlipressin did not improve 90-day survival as compared with placebo, with 51% versus 45%. Patients in the terlipressin group were more likely to have respiratory failure and to die from respiratory disorders within 90 days after the first dose, 11% versus 2%, which may have contributed to the numerical difference in mortality. The incidence of serious adverse event was higher in the terlipressin group than in the placebo group. Abdominal pain, skin discoloration, intestinal ischemia, cardiac ischemia, cyanosis, bradycardia, and diarrhea are well-recognized potential adverse events of terlipressin. So bottom line, terlipressin was more effective than placebo in improving renal function, but was associated with serious adverse events, including respiratory failure. In July 2020, the FDA Cardiovascular and Renal Drugs Advisory Committee narrowly voted 8-7 in favor of the approval of terlipressin for HRS1 based on data from the pivotal phase 3 CONFIRM trial that we just went over. Results showed that terlipressin met the primary and key secondary endpoints demonstrating HRS reversal. However, in meeting documents, the FDA committee noted that an exploratory analysis of treatment effects on clinical outcomes showed terlipressin was not associated with improved survival compared with placebo. The committee also raised safety concerns regarding respiratory failure events. So in their complete response letter, the FDA stated that the application could not be approved in its current form and that more information to support a positive risk-benefit profile is needed. Dr. Romano, the Executive Vice President and Chief Scientific Officer at Mallinckrodt Pharmaceuticals, made a statement that they remain committed, of course, to working with the FDA toward approval of terlipressin. But as it stands right now, terlipressin is not approved in all countries, including the US. So in discussing pharmacologic therapy, let's move on to other vasoconstrictive agents in combination with albumin. Norepinephrine, which is given intravenously at a dose of 0.5 to 3 milligrams per hour, is an alternative agent that has been shown in small studies to be effective in increasing arterial pressure and reversal of kidney impairment in patients with HRS. However, a recent controlled trial suggests that norepi is inferior to terlipressin in reversal of HRS, kidney replacement therapy requirements, and overall survival. The combination of midodrine plus octreotide used in countries where terlipressin is not yet available has been shown in single center study to be less effective than terlipressin. And I just want to reiterate once and all for the people in the back that the limitation to norepinephrine is the need for a central line and admission to ICU for monitoring, which we all know right now is not something that's entirely feasible with our numbers in our ICUs. Going further into other treatment options, for hepatorenal syndrome, I have to talk about TIPS. Theoretically, a TIPS or transjugular intrahepatic portosystemic shunt may improve kidney function in HRS by decreasing the portal hypertension and reversing the circulatory changes and possibly systemic inflammation that precipitate HRS. A systemic review and meta-analysis was performed in which 9 publications and 128 patients with HRS treated with TIPS was reviewed. Following the procedure, they evaluated labs including serum creatinine, BUN, serum sodium, sodium excretion, as well as urine volume, and found that they had improved, though it was not statistically significant. This limited evidence suggests a potential survival benefit of TIPS in patients with HRS, but there was a high incidence of hepatic encephalopathy. So in addition to TIPS, I do need to discuss the utility and role of kidney replacement therapy in this patient population. Initiation of kidney replacement therapy in patients with HRS is controversial and has typically been viewed as a bridge to transplantation. Recent studies have demonstrated that the severity of illness and number of organ failure in patients with acute on chronic liver failure is more predictive of 28-day mortality than the cause of AKI. Therefore, it seems reasonable to consider a trial of kidney replacement therapy in selected patients, regardless of transplant candidacy. The ideal timing of initiation of kidney replacement therapy has not been studied in patients with cirrhosis, and so it should be individualized and made on clinical grounds, such as their worsening kidney function coupled with electrolyte disturbances, not responding to medical management, or diuretic intolerance or resistance. Kidney replacement therapy should also be considered if the daily fluid balance cannot be maintained, regardless of their urine output, or to prevent fluid accumulation. Besides kidney replacement therapy, we should talk about liver support system, specifically MARS. So the use of extracorporeal albumin dialysis by the molecular adsorbent recirculating system, or MARS, has been shown to remove protein-bound substances and decrease the plasma concentrations of bilirubin, ammonium, and creatinine in patients with acute on chronic liver failure. In these patients, treatment with MARS was also associated with relevant hemodynamic and clinical effects, such as a decrease in portal pressure, improvement of the hyperdynamic circulation, as well as hepatic encephalopathy. In a randomized trial of patients with acute on chronic liver failure, there was no significant difference in 28-day mortality between patients with HRS who underwent MARS therapy compared with standard medical therapy. So at this time, there is no evidence that albumin dialysis is superior to conventional filtration in patients requiring kidney replacement therapy. So next, discussing liver versus simultaneous liver kidney transplantation. Predicting the recovery of impaired kidney function and the extent of that recovery after liver transplantation is challenging. because of difficulties in delineating the relative contribution of the pre-existing comorbidities, unrecognized intrinsic kidney disease, perioperative events, as well as post-transplant immunosuppression to kidney dysfunction after a liver transplant. The development of AKI before liver transplantation has been shown to be associated with higher risk of CKD, as well as end-stage kidney disease in the long term after liver transplantation. But it's also been associated with increased risk of mortality. So a study published in Jason in 2013 reviewing liver transplant recipients who received acute kidney replacement therapy for less than or equal to 90 days before their transplant showed that only 9% had kidney non-recovery and needed chronic kidney replacement therapy within 6 months of their transplant. However, in that group or cohort, the post-liver transplantation mortality was high. The treatment of choice for patients with hepatorenal syndrome is liver transplantation. And in theory, kidney function is fully reversible post-transplant. There was a retrospective analysis in 2012 that was published in the American Association for the Study of Liver Diseases, in which it was reviewing patients who underwent liver transplant at this particular center after MELD-based allocation and reviewed the impact of the etiology of AKI. So specifically, they were looking at and grouping it into ATN versus HRS as a cause of AKI before liver transplant. Then they reviewed the post-liver transplant outcomes. It was shown that patients with HRS had significantly higher kidney recovery and patient survival compared to those who had ATN before the liver transplantation. And this was comparable with those patients who did not have AKI, which is echoing that first statement. As I said, theoretically, kidney function is fully reversible post-transplant. So this is a figure from that paper showing the impact of the etiology, again, of AKI and outcomes following liver transplantation. So if you're looking here, you'll see the dot and dash line represents ATN is the etiology of the AKI, whereas HRS is represented by this solid line here. X-axis is looking, of course, at time after transplantation, again, referring to liver transplantation. And then the y-axis is looking at the cumulative incidence of CKD. And you'll see it's much higher in the patient population with ATN as opposed to those who are determined to have HRS. So the patient survival renal outcomes at 1 and 5 years after liver transplant was significantly worse for those with ATN. At 5 years, the incidence of CKD stage 4 or 5 was statistically higher in the ATN group versus the HRS group. 56% versus 16% with a p-value of less than 0.001. This study is the first to demonstrate that the etiology of AKI has the greatest impact on patient and renal outcomes after liver transplantation. So the introduction of organ allocation on the basis of MELD in 2002 resulted in this dramatic increase in the number of simultaneous liver and kidney transplantations because of priority and allocation to liver transplantation candidates with kidney dysfunction. I just thought this is a really good bar graph representing that because there's no denying when you look at the trend over time from 2000 to 2014, as I said, it really took off with the introduction and change in 2002. Looking, of course, at the number of simultaneous liver kidney transplants per year. So simultaneous liver kidney transplantation now represents 10% of all liver transplants in the United States, with approximately 5% of transplanted deceased donor kidneys drawn away from the kidney transplant-only candidates, raising some concern in the kidney transplant community, especially given the uncertain benefit of simultaneous liver kidney transplantation. The decision to perform a simultaneous liver kidney transplantation versus a liver transplantation alone is driven not only by the concern of increased mortality post-transplant, but also by the concern of lack of kidney recovery, which is felt to contribute to the increased mortality. Studies have shown that post-liver transplantation patients on the kidney waitlist have a higher mortality compared with patients waiting for kidney transplant only. As represented here, it's the highest or most elevated line in this particular figure that shows the patient's survival after placement on the waiting list by presence and type of previous transplant, which was from the prior journal. So recently, listing criteria for simultaneous liver kidney transplantation were developed by the Organ Procurement and Transplantation Network on the basis of prior consensus and recommendations, which include factors such as duration of AKI and dialysis and evidence of CKD. As you can see here on this table, factors such as age, comorbidities, or cause of AKI, which could affect kidney recovery, are currently not included in this criteria. Now moving on to biomarkers involved in AKI and liver disease. So early diagnosis and identification of the phenotype of AKI is crucial as management differs according to different causes, which again, we covered at the beginning of this presentation. So conventional tools such as urine output or fractional excretion of sodium or urea have been shown to have significant limitation in patients with advanced cirrhosis. And there's poor correlation with biopsy findings. So recently, several innovative biomarkers have been studied, including NGAL, KIM1, liver fatty acid binding protein, and IL-18, those being the most extensively studied. These specific biomarkers typically reflect the earliest markers of ischemia-related events and may play a role in the diagnosis of AKI before liver transplantation. These biomarkers are not specific to kidney injury and may be influenced by inflammation or infection. They also do not comprehensively discriminate dichotomous outcomes and have not been validated using kidney biopsy as a gold standard. In addition, there is substantial overlap that has been observed between the different phenotypes, and no clear cutoff value separates HRS from ATN diagnosis. These biomarkers are predictive of recovery from AKI after liver transplantation could enhance decision algorithms regarding the need for liver kidney transplant or kidney sparing regimens. So furthermore, there's these tissue inhibitor of metalloproteinase 1 and osteopontin, along with patient characteristics such as age and diabetes, have been shown in this single center study to differentiate between recipients that developed reversible versus irreversible AKI after liver transplantation. In addition to those novel biomarkers that I was just mentioning, imaging studies have also been a place of interest or have a role in the utility to help delineate and differentiate between this AKI, again, in the setting of liver disease. So kidney ultrasonography is a useful, non-invasive test to help exclude structural causes of AKI, such as obstructive uropathy and intrinsic parenchymal kidney disease, which would rule out the diagnosis of HRS. Assessment of arterial kidney resistive indexes by Doppler ultrasonography, contrast-enhanced ultrasonography, and magnetic resonance elastography have been shown in very small studies to be associated with the development of HRS. Whether these techniques help in early diagnosis of HRS, differentiation of HRS from other phenotypes of AKI, or prediction of response to vasoconstrictors needs to be further explored, though, in larger trials. So in conclusion, there have been significant improvements in diagnosis and management of HRS, as we've seen and gone through all the options that we have now and all the studies that have just even recently come out within the last couple of years. However, even with vasoconstrictors and albumin use, the 3-month mortality rates without liver transplant remain high in this really unfortunate group of patients. In addition to splanchnic and systemic circulatory changes, inflammation may also play an important role. Therapeutic interventions aimed at controlling the inflammation may help prevent or reverse HRS. Novel biomarkers in combination with imaging may improve diagnosis of AKI and cirrhosis. And looking ahead, biomarkers and imaging studies may also help affect the decision to allocate simultaneous liver and kidney transplantation. Just a couple of pages of references. And thank you for joining me today for my Grand Rounds.
Tricia, that was awesome.
Thanks.
Hey, Tricia. I'm glad you brought up the resistive indices. I use that a lot in the hospital. I find it very helpful, and it's one of the few tests that we currently have.
Yeah, I appreciate that. I think that's a good point to remind us as, again, non-invasive testing or further evidence or data we can gather in evaluating these patients. So certainly has a role.
Good job, Tricia. I want to say something about biomarkers. There was a study from the tribe AKI. I should have told you about it before the grand rounds, where they clinically classified patients as HRS or AKI on the basis of clinical decision. Then they looked at biomarkers, and they did find that the biomarkers were lower in the patients that were clinically classified as HRS versus ischemic AKI. So we're working with Mallinckrodt on the advisory board. They're interested in doing a study of biomarkers in their patients in the confirm study, because if you look at the confirm study, there were about 10 patients that did not respond to terlipressin. And those patients that did not respond to terlipressin may not have responded because they were not HRS, they were ischemic AKI, and you should be able to diagnose that based on biomarkers. So they would be interested in looking at biomarkers in those patients. That makes sense, right? The patients that wouldn't respond to terlipressin would be patients with established AKI, and we should be able to diagnose that on the basis of biomarkers.
Yeah, it does make sense. And that's just a really interesting direction to be able to go into to show and delineate between the two with the use of, again, of the biomarkers. I think that'd be really helpful in the future with that. Yeah.
Trish, Stu here. Nice job. Enjoyed. The one thing I would like to just add that I don't think was mentioned is that when we look at our vaso or norepi response rate at Denver Health, the initial response rate is really pretty good. Where things break down, we think, is that all you've done with that is buy time for something else to get better, for the SBP to go away. But more often, it's alcoholic liver disease for the liver to do its thing and get better, especially in alcoholic liver disease. And so the breakdown is, in addition to the pressors that buy you time, we think it takes, and I'm exaggerating here, 2,000 calories a day of nutrition to really buy the time. And it often doesn't happen in a couple days. It often can be a week, 10 days, 2 weeks in the ICU, and everyone loses interest. So the bottom line is that many, many people respond to pressors. Some have adverse reactions, as you alluded to. Many don't, but don't seem to get better because I don't think we do a particularly good job of total body care, especially nutrition, in these folks.
I think you bring up a great point. Thank you for really highlighting that, because you have to, or something that I took away from this is just reminding myself that they're in such a high inflammatory state as well. And as you point out, the calorie and nutritional intake, in addition to that, just to have everything kind of calm down, does take time. And that's a really valid point, that we're buying time to allow for total body care to also occur.
This is Sarah. I just wanted to build off of what Stu said, that I think we spend a lot of time trying to distinguish HRS from ATN, which I'm not sure is the most important point. Like if somebody has a little bit of ATN and a little bit of HRS, I think we would still go with vasopressor treatment. And really the most important factor in these decisions of how we treat and what we treat with is how likely we think the liver is going to get better and how likely we think the overall patient's going to get better. So I've kind of changed my practice. I don't spend so much time worrying about ATN because they all seem to have underlying HRS physiology and might benefit from vasopressors. So I think that's an important point.
Yeah, definitely. Thank you for bringing that up as well. It does seem, at least coming across a lot of these papers, that was a main focus of, as you said, the ATN versus HRS, but looking as far as an overall arching picture, yeah, there's no denying that there's the HRS physiology there that's present, and yeah, that's a great point.
Tricia, first of all, congratulations on a great job. I just curious, in terms of the inflammatory response, I don't think I heard this. Has there been anything looking at IL-1 receptor antagonists or other anti-inflammatory agents?
That's actually a really good question too. I didn't, in my research and preparing for this, I didn't come across as much from that. If anything, I was more surprised about the comments and effects of albumin being an anti-inflammatory effector there, but I didn't find anything specific about targeting these IL receptors.
Isaac, that has not, Tricia, also great job, and I apologize again for joining late. But Isaac, none of this anti-inflammatory has been tested in HRS.
Thanks.
Yeah, my understanding of the inflammatory hypothesis is it's more related to bacterial translation and maybe endotoxin related and maybe NO related. So I'm not sure. I think it's unlikely that IL-6, like that the cytokines are necessarily the major factor, but I think it's endotoxin and NO related.
Yeah, I want to just glom on what Sarah said. Pretty good data that the source of the NO or the LPS is gut bacteria that then activates downstream systems. There's good old data, and you showed a little bit of it, but in HRS, if you treat people acutely with something like a non-reabsorbable aminoglycoside, I believe the studies were with kanamycin, not neomycin, and there are other studies with levo acutely, you improve hemodynamics, but the problem is you just repopulate your gut with a whole bunch of organisms that are drug resistant. So the inflammatory component comes from activation from the gut, most likely, at least in many of these forms of liver disease.
Yeah, another treatment that's been looked at is vasoconstrictors. I mean, when Chirag Parikh was a fellow, his K grant with myself and Dr. Schreier was looking at L-NAME, which is a nitric oxide inhibitor that causes vasoconstriction in hepatorenal syndrome. And basically that study was really negative. L-NAME, which should have worked in hepatorenal syndrome, didn't really work that well. And also, by the way, Mallinckrodt seems to think that terlipressin will be approved with a warning that it should not be used in patients that are volume overloaded. They're going to get that kind of put into the package insert, and they're going to get it approved with certain conditions.
Charles, what does that mean? They're all volume overloaded.
Well, I don't know exactly what the wording is going to be, but they're not all volume overloaded. Some of them are. I'm talking about pulmonary edema or predisposition to pulmonary edema.
So not volume overloaded, pulmonary edema, because they all have ascites, plus or minus peripheral edema.
Well, intravascular volume overload.
That's a tough one.
So I just wanted to echo something Dr. Sarah Fauble said, which is I am so much less interested in this distinction between HRS and ATN with time. And one of the other things is we don't really know what pressure we should be vasoconstricting these patients up to, like in terms of Levophed and Midodrine. And so I've started to just, sometimes people say it's not HRS because they're not that hypotensive, but there's such a disparity in the vasoconstriction in the different vascular beds. And sometimes I put these people on Midodrine and it seems to improve their kidney function. So I would just really like to know what's the map we should be targeting for, to help in this situation.
So Sarah, all I can tell you, I mean, I don't think we have that data. And so I think that what we do is that we keep pushing it until someone's fingers turn blue, their gut turns ischemic, i.e. they've got lactate, and in essence, push to a systolic pressure that's 20 or so above whatever it was before. But that clearly is not a data-driven recommendation. It's an experience-driven recommendation.
Okay, but let's say your MAP is 65 when you see the patient, but they have hepatorenal physiology. Are you pushing them to a MAP of 85? Is that what you're telling me?
Yeah.
Okay.
Or
Yeah,
until until their fingers, I'm exaggerating, their fingers turn blue or they
Right.
develop a lactic acidosis.
Yeah, I think that's consistent with what I would like to do. The challenge is sometimes we get pushback that it can't be HRS because their MAP isn't less than 65. And I don't know who thinks, people think that. I actually have found the ultrasound renal resistive indices to be helpful in that situation, because I've had patients whose MAPs weren't that low. We've gotten resistive indices, they were elevated. And I was like, this is HRS up the map. So that's why I really like the ultrasound. It's one of the few things we have to add to our armamentarium.
Yeah, my
thought-
practice has been to drive up the maps as well. I think Up to Date used to have a recommendation of, I think, a map of 85 or maybe 80, something like that. So I think we've all thought of 65 as the target, but I agree that it should be higher in HRS.
I think the differentiation between AKI and HRS is life-saving in certain patients. As you know, we have patients that are not going to get a liver transplant, and we have to decide if we're going to dialyze them. And if they're pure, if we think they're HRS, we're not going to dialyze them. And if we think they have like AKI, we are going to dialyze them. So it's a very difficult decision to make, because you're deciding whether a patient lives or dies. So to me, it's important to be able to at least get an idea of which one the patient has, right?
Charles, let me push back on you a little bit. And I had to drop out for a minute or two. So if Tricia, you covered this paper, Slow Me Down, about 2 years ago in the Lancet, and I'll send it around. And I've got a weasel on that, whether it's the Lancet or NDT. There was a nice study saying it doesn't matter if it's HRS or ATN, the 30, 60, and 90-day mortality is the same. So going back to what a couple people have already said, that all the old stuff we've done trying to distinguish them, at least as far as 30, 60, or 90-day mortality, doesn't make a difference. That said, if there is a difference in their eligibility for liver transplant, then obviously that's different. But at least our experience is that it doesn't seem to matter. So bottom line is, spending this amount of time trying to figure it out, at least right now, doesn't seem to be very helpful as far as long-term mortality.
Yeah, we might be talking about the same paper. There's also one in C. Jason. I think Allegretti, something like that, is the first author. And that's something that's really changed my practice as well, is not trying to fuss so much about HRS versus ATN, given those similar outcomes.
Yeah, to jump on that, he really discussed the role again of kidney replacement therapy. And I got a chance to see when you introduced him actually at ASN talking about that as well too. So that's kind of changed my perspective on, at least separately from that, identifying the AKI etiology, but more or less the role of kidney replacement therapy in this patient population.
Thank you, Tricia. Great job. Thanks,
Thank you,
everyone.
everybody.
Sure.